Son gün son.
Welcome. Last day, last session. I hope that I'll make a fruitful presentation. My presentation is in line with the content of our session. We know that addiction has different aspects. It's such a syndrome, but although we think about the physical part of addiction, we do not focus sufficiently on the cognitive or emotional aspects of it. In my presentation, I'll briefly talk about the treatment, importance of treatment, the techniques we used in therapy, our clinical practice, and the role of cognitive therapy. And 5R approach will be dealt by me. Happiness and freedom begins with a clear understanding of one principle. Some things are within our control and some are not. This is the core of cognitive behavioral therapy and how we can translate it into addiction treatment. Smoking addiction is an addiction itself and we can control it, but we should think that there is a psychological and behavioral aspect, and cigarettes is considered as a basic need. If we make our patients feel like that or understand that, then we can be successful. Cigarette is illegal and which is not criticized very much by the people, by the society. So we are approaching to it as if it's different from other drugs, other substances. However, we should be very careful about this addiction. There is a very saddening data from Turkey. And Turkey is within the top 10 countries in the world. For Eastern Europe, there are some studies evaluating males, and Turkey is at the top of these lists, and women is there in the group which is less successful in quitting smoking. So this is a huge public health problem. Nearly 70% of cigarette users want to quit smoking. This is a big number. However, despite that wish, only 5% of them are successful in quitting it, and most of them start smoking again within 6-12 months. So although there is such a will, why the results are that unfavorable is showing us that the physical aspects, psychological aspects are underestimated. There are many methods and none of them are 100% successful, but as mentioned by Bengü, patient-oriented cognitive behavioral therapy is helping us a lot. For psychological treatment, there are more than one psychological treatment, but motivational and cognitive behavioral therapy are musts in cigarette smoking or musts in quitting cigarette. During Vietnam War, an observation was made, and the US soldiers, most of these soldiers were abusing substances, and 20% of them meet the addiction criteria. And the problem occurs when the US soldiers return back to the USA. Our streets will be packed with addicts, but after they return to their own country, only 5% of the US soldiers continued using upon their return. It points to the fact that if there is a stress, if there is distress, if you are not comfortable with your safety, and if there are so many negative things, like if you do not have a family waiting for you at home, if you do not have a job, if your life is at stake, then all these are triggering factors for abusing a substance or becoming an addict. So, motivational therapy has a role at that point, and the biggest role is to identify the ambivalence. When you find this ambivalence, you continue this and focus on the change and resistance to change. Here, it's not only sufficient if you are motivated, but your patient should be motivated too. So this motivation of change should come within the patient himself, herself. There are stages of change, and treatment has a role. We know that there is a circle, and we say that when you examine the patient, if possible, please know or please reach a decision on the stage of the patient. First of all is the awareness. You should be aware of the stage of the patient. So for awareness, if you see a patient, you need to get him involved in the awareness. And during awareness, ambivalence kicks in, starts kicking in. And the biggest group of cigarette addicts are in this group. For instance, there is a group which started smoking after quitting again. So if we can find it, our biggest motivational factor is that if you do not stop smoking, what are the advantages of not smoking, So advantages and disadvantages of cigarette smoking is discussed with the patient, and then we will help the patient to complete the circle. And then comes the intent, then comes the action phase. So it will be followed by continuation. So the recent data considers that 6 months of non-smoking means that she is stopped for good and won't continue. How about the cognitive therapy? In cognitive therapy, there are more than one model, but we mainly focus on 2 models. First of them was found in 1985 by Marlett and Gordon. Bandura's social learning and self-efficacy theories. It's to prevent relapses. If there's a high-risk situation, then the coping mechanisms should be looked at. If there is good coping mechanism, if self-efficacy is high, then even under high-risk situations, there is a decreased possibility of relapse. However, if coping mechanisms is not sufficient, if he is in expectation of positive outcomes when addicting, when using or abusing a drug, and if there is a sensitivity for abstinence, then most probably that there will be relapse. So even after quitting it, he will start using it again. Another model, the second model, which was found by back in 1993, it's quite similar to preventing relapse, but beliefs are at the core. So he says that our intrinsic and extrinsic stimulus, our beliefs are activated. And when, for instance, if you are sad, if you are happy, or For instance, there's a very good view, scenery in front of you, which evokes smoking a cigarette. So this is about activation of beliefs. First, core beliefs are activated, and then they are followed by the thoughts on your brain. And these automatic thoughts, when they are there, you feel a craving, you feel an urge. And after craving, then facilitating factors come to the fore. Let me smoke one cigarette and it will be my last cigarette. Or let me finish this pack and it will be my last pack. Or I'm alone today, or I'm so sad today, so let me smoke one or two cigarettes. This leads us to relapse. So beliefs are very important. So in our own clinic, a patient comes to you, you evaluate the patient and realize that he is aware of his situation. And if you believe that this patient can quit smoking, then automatic thoughts and beliefs, you should create an awareness for the patient. If you can create such awareness, most probably he will quit smoking, and this will be done in a successful way. When an addict comes to you, what are the psychological factors? First of all, if there's a substance, there should be a motivation to start abusing it or quitting it. So everything starts with motivation. Then cognitive factors are followed. For a high school student, if the child is scared that I won't be accepted to the circle of my friends, then I should start smoking. Or there are behavioral factors. Maybe he's very accustomed to smoking a cigarette, or there may be some poor coping mechanisms, like I'm in a huge stress and cigarette is a must for me. Or there is or they may be in search for a stimulant. What is this search for stimulant? Natural stimulus will not be very pleasurable for him, so he may start smoking. Impulsivity is another factor, or they may want to feel good or get rid of negative feelings. So negative emotions have a role in addiction. For smoking addiction, there are three important situations. First of them is classical condition, mentioned in detail by Ayşegül. Then operant conditioning. So a tea glass may be a stimulus for smoking, or a scenery can be a stimulus for smoking, or seeing a friend may be a stimulus for smoking. So these are about this classical conditioning. The second one is the operant conditioning. These are supported by enhancers. So when you abuse a drug, a substance, there are positive factors. But when someone is feeling very sad, he may resort to cigarette smoking, which becomes an operant conditioning. And then comes compulsive cigarette smoking. What do we do in our treatment? So if CBT is possible,
tamam. Buralara yapabilirsek eğer müdahaleleri,
if we intervene at that point, then we become more successful. Motivation is a must in addiction, so please first be aware of the motivation level of your patient. Psychoeducation is a very significant method to get feedback, and classical and operant conditioning and cognitive restructuring, prevention threshold, and problem solving, communication, acquiring new skills during the therapies, and most importantly, some specific personal interventions if there is a special triggering factor. So how do we do this? It's similar with our regular CBT techniques. Socratic questioning. There may be advantage, disadvantages analysis, imaginations, downward arrow technique. So classical or regular CBT techniques can be utilized for smoking or for addiction. For behavioral techniques, they are not different. Daily activity tracking or monitoring is very significant, because monitoring reduces the frequency of actions. This is the same for eating disorders. Like I eat snacks. We ask, what kind of snacks do you eat? Write it down. Or I drink something. What do you drink? Write it down. So writing down these activities is something very good to realize the behavior and to control it. If the patient is not doing this, it means that the patient is not highly motivated. And then there will be relaxation exercises, physical exercises to manage stress, and other behavioral techniques can be used. 5A, 5R is a must for addiction treatment. So if for any reason tell your patient that, do you smoke or are you smoking, it means that you are increasing the risk of that patient's smoking. So when you are writing a prescription, if you ask, do you smoke, then it means that it increases the risk of smoking by 3%. First, providing information, giving information, very basic, very simple information has a good role. It has a good role to create awareness. For instance, if the group is willing to stop smoking, then we should utilize 5A. First, we ask, no matter what the reason, we should question the smoking behaviors. And what does he abuse? Only cigarette? No, it covers all tobacco products. So to raise the patient's awareness, we ask questions like, when do you smoke? Did you quit before? Etc. If the patient is already smoking, then we should give advice to the patient. We should warn the patient. There is no single standard formula. Like the patient comes to me and my child is growing old and I'm very sad and I'm a bad example in front of my child, then we give advice accordingly. However, there may be another patient coming to you saying that I'm financially in a very difficult situation and I need to allocate all my scarce finances to smoking. Then you give advice accordingly. Then comes assessment. We need to assess the situation as well. So the patient is highly motivated. He wants to quit smoking, and there is this awareness factor fulfilled, or there is the preparation factor fulfilled. So risky conditions should be evaluated. Previously, the patient stopped smoking, but restarted again. We need to look at that. If during your measurements your patient is not very willing, then you go into 5R, which is available to those who are less willing to quit smoking. You identify a date. For instance, if the patient is willing, it should be within the first week. Within that time, the patient gives information to his family or his surrounding at work or at social surrounding that I am quitting smoking, and pharmacotherapy alternatives are explained to the patient, and in respect of treatment and extra treatment, social support will be provided. For instance, the patient quit smoking and 2 days later a huge problem occurred, so if possible that patient needs some support for 2 or 3 weeks. For instance, I quit smoking and I have a very close friend and there is an urge to smoke. If this is the case, there should be someone whom he can call and get support from his family or friends. And coping mechanisms and solutions should be given. Could you please wrap up? Additional information resources are important. Stress relieving activities are recommended. 5A's last point is the arrangement. For those who are not willing, when the patient comes to you, first you should build a relevance, or you should establish a relevance. Like you are smoking, and is there any relevance between your smoking and between your anxiety? And risks should be explained, including general medical field as well. And each and every dose is risky. What are the probable risks and obstacles? Individual solutions should be devised, and if possible, a repetition. We shouldn't be deterrent to our patients. And cigarette smoking is a substance abuse or substance addiction. So there are some studies which show that sometimes people need to repeat it, and Mark Twain's words should be reminded to patients. Cigarette smoking you can quit smoking, and I quit smoking like a few times. Thank you.